Welcome to our channel. In this video, I'll talk about the treatment for an Achilles tendon injury that isn't immediately recognized and is therefore no longer suitable for anatomical repair, as we do in most cases. I remind you that the Achilles tendon is one of the largest and strongest tendons in the human body, and that it arises from the union of the tendon fibers of the calf muscles until it attaches to the heel bone, which is called calcaneus. The Achilles tendon exerts a strong plantar flexion action, allowing us to stand on tiptoe and also to propel ourselves forward when walking. As I mentioned earlier, when the Achilles tendon ruptures, we generally rebuild it to reduce the risk of a second rupture in the months that follow. I therefore refer you to the specific video for the surgical treatment of fresh tendon injuries. However, the treatment for an old Achilles tendon rupture is completely different, or if the Achilles tendon, while not ruptured, is in severe chronic pain due to local inflammation that may have started several years earlier and is now very painful and no longer functional. I present the case of a patient in his 70s who, after a seemingly trivial injury, didn't bother going to the doctor for a checkup, believing it was just a simple ankle sprain. In reality, it was a complete rupture of the Achilles tendon, which several months later still forces him to walk awkwardly and with a noticeable limp. The diagnosis is very simple, requiring only a history of the trauma and a thorough examination of the patient. It may then be helpful to request a test such as an ultrasound or, even better, a magnetic resonance imaging (MRI) scan, which is much more accurate. Given the patient's symptoms and functional impairment, after discussing the type of surgery and its risks, which we will discuss at the end of this video, we decided to undertake surgical treatment. The anesthesia generally proposed is a spinal anesthesia, that is, by injecting an anesthetic into the back, or a general anesthesia, also called narcosis. The surgery is performed with the patient supine, that is, lying on his back, and with a pneumatic tourniquet at thigh level, to prevent bleeding and help us perfectly identify the deep anatomical structures. The surgical incision is a few centimeters long and is made on the inside of the ankle, behind the medial malleolus. We can now easily identify the Achilles tendon, which is visibly swollen. This tendon also has a complete rupture within it, which, however, over the weeks following the injury, has undergone extensive scarring, but in a clearly non-functional manner, leaving the patient with significant disability. We now come to the key point of the surgery: how to replace the now irreparable Achilles tendon with a replacement structure. In this specific case, this involves identifying and harvesting the flexor hallucis longus, shown here. It is then sectioned and brought back to the area where the Achilles tendon normally attaches. To do this, we need to create a tunnel within the heel bone through which the detached tendon will be passed. The question patients most frequently ask me when I suggest this type of surgery is, how will I walk without the flexor hallucis longus tendon? In other words, they ask me what the consequences of sacrificing this tendon are. Indeed, it is an internationally recognized surgical procedure performed by every foot surgeon. For this problem, we must consider that we are sacrificing a relatively unimportant tendon, which is the flexor hallucis longus, in favor of a tendon with a much more important function, the Achilles tendon. In the vast majority of patients, sacrificing the flexor hallucis longus tendon does not cause any problems with walking or everyday life, but it could cause some problems in runners or professional athletes. It must be considered that removing the flexor hallucis longus tendon does not necessarily equate to completely losing the toe's flexion mobility, that is, the ability to bend it downward. Let's now return to the operating room to see how the tendon is easily identified with the help of the assistant, who moves the big toe up and down, thus facilitating the tendon's movement and allowing for its identification. After cutting the tendon, an absorbable thread is inserted. The next step involves creating a tunnel a few millimeters in diameter inside the heel bone using a drill. As I mentioned earlier, the tunnel is created at the same insertion site as the original Achilles tendon. Once the tunnel is created, the tendon is simply passed through it and locked in the desired position using a absorbable screw approximately 6 or 8 millimeters in diameter, which is completely embedded within the bony tunnel. The final stage of the procedure involves closing the deep layers with absorbable sutures, first and then the skin. After applying a sterile dressing, we must obviously protect the new tendon, preventing the foot from accidentally bending upward, which would place excessive stress on the reconstruction we've just performed. We then apply a cast, or more commonly, a long boot-shaped brace like the one pictured. In both cases, the foot is initially positioned at 20 or 30 degrees of downward flexion. Typically, this flexion position is maintained for the first 2 or 3 weeks, after which the foot is gradually positioned at a more neutral angle. In other words, at the beginning of the 2nd or 3rd week, the brace will be adjusted by 10 degrees at a time, once a week, reaching the so-called neutral position around the 4th week. The foot remains at 90 degrees to the axis of the leg. For the first 2 weeks, despite the protective brace, it is best not to put weight on the ground. Only from the 3rd week onwards, it is allowed to put some weight on the floor, still with the brace, and then gradually increase this over the following weeks until full weight bearing is achieved. During this entire period, 2 crutches will be required. Some patients, in addition to the 2 crutches, find it very convenient to use a wheeled walker, not only for more secure support when walking, but also to use it as a sort of wheelchair, as this patient does. After surgery, it's very important to always try to elevate the operated foot to prevent swelling and possible pain or scarring. Many patients are rightly concerned about the potential pain they might experience after surgery. I can reassure all these people because thanks to modern surgical techniques and anesthesia, post-operative pain is minimized, allowing patients to stop taking painkillers just a few days after surgery. To reduce the risk of deep vein thrombosis, it's very important to follow a 6-week prophylaxis with low molecular weight heparin. The skin stitches are absorbable, so there's no stress in having to remove them. After surgery, avoid getting the foot wet while taking a shower or bath. If you really can't stand washing yourself with just a sponge, you can use waterproof bags available at the pharmacy. It's always best to wrap them in kitchen cellophane too, to make them even more waterproof and resistant. Obviously, as with all surgical procedures, there may be risks and complications that should be discussed with the surgeon before the procedure, specifically 1. Infection, 2. Deep vein thrombosis, 3. Swelling, 4. Persistent pain, 5. Loss of sensation in part of the foot, or 6. A new tendon rupture. These are all possible, but unlikely complications. It should be noted that this type of procedure will require several months of physical therapy to achieve a satisfactory result. In most cases, this can take up to 6 months after the procedure. The most frequent complication but one that does not change the generally very positive opinion of patients, is the sensation of reduced flexion strength in the foot, with the consequent possible difficulty in standing on the tip of the operated foot, alone, running, or even walking, for example, uphill. If you think this video was helpful, or if you think it could be useful to someone else, please like and subscribe to the channel.